So good afternoon, everyone. I'm Dr. Saresh from the Khan University Hospital, and I'm going to present the prevalence of hypovitaminosis D in patients with uveitis presenting at a tertiary care hospital. So hypovitaminosis D is the term that we have used for the patients having insufficient and deficient levels of vitamin D. So vitamin D plays an important role in immune modulation. Vitamin D receptors are present on the immune cells and they are thought to hold inherent activity in non-infectious autoimmune uveitis, as multiple studies have been previously conducted showing that hypovitaminosis D has been associated with autoimmune uveitis. So vitamin D uveitis is also is being regarded as inhibiting the action of type 1 helper T cell pathway. So vitamin D also induces antituberculous activity in vitro in both monocytes and macrophages. So the objective of my study was to determine the prevalence of hypovitaminosis D in patients with uveitis presenting at a tertiary care hospital, and the subgroup analysis was done on the basis of gender and the IGRA status. So this retrospective study we conducted between January 2017 to September 2021 at the Department of Ophthalmology and Visual Sciences at the Khan University Hospital, and included patients aged between 18 to 75 of years and any type of uveitis that patients are presenting with complete documentation of the laboratory workup and the type of uveitis and at least vitamin D blood levels which were done. So we found out about 120 patients of uveitis during this period that out of which we have to exclude patients based on the eligibility criteria, and we included about 63 patients, and out of those there were males and females with more about 50%, 50.7% female, and as we can see that in males there were about 3% of the males that had normal vitamin D levels in comparison to females, in which 45.9% had normal, in comparison to males, have had hypovitaminosis D. And if we compare females, so the normal levels were in about 10 of the patients, and abnormal levels were there in about around 30 patients. So, the majority of the cases were with unilateral disease, and that was about 26. And then we had more of the patients with panuveitis there, and followed by anterior uveitis and the posterior uveitis. So, as we can see that in hypovitaminosis D, which was 80% of the all sample that we had, about 71% were deficient and about 9.52% insufficient. And the median levels, as we can see, was higher in females and in comparison to males. So hypovitaminosis D was more prevalent in males. So if we compare the relationship to gender, we found out that the median levels were higher in females, which was about 17.85 nanogram per ml, and it was 11.4 nanogram per ml in males. Whereas if we compare it with IGRA, so there was a statistical significant relationship between both the groups, IGRA positive and negative, in comparison with normal. So similarly, among 36 IGRA negative patients, we found out about 32 had statistical hypovitaminosis D and about 4 had D deficient levels. So a study showed a high prevalence of hypovitaminosis D in uveitis patients, more in males in comparison to females. It was significantly present in both IGRA positive and negative patients, and obviously more prospective case control studies and with sufficiently larger sample size are required in order to find the direct association of low vitamin D levels with the uveitis. Thank you so much. Any questions if there?
Okay, what is the percentage of patients with hypervitaminosis D in uveitis in your group A and B, male and female?
So it was 60, there were about 70% were deficient and about 9% were insufficient. So if we combine it, there were about total of 80% which were hypovitaminosis D compared both males and females.
So what did you conclude from that? That uveitis is related with vitamin D problem.
So basically, the previous studies that we were looking at had insufficient or deficient levels of vitamin D in autoimmune uveitis. But in this case, we included generally all uveitis population, and then we compared if they have sufficient levels of vitamin D or not. But there is one limitation to this study is that the general population of the Pakistan, as per the survey that was conducted recently, had about 70% of patients already deficient. So that may be representing to our population, and that is the reason that further trials and case control studies would be helpful in finding the direct relationship.
Has there been any recommendation for using vitamin D in the treatment of uveitis?
Yes, exactly, sir. So this is one of the idea for future research, as we are thinking that these patients who had deficient levels, these patients with uveitis, we can actually give them supplements and then we follow them over a certain period of time and see if their uveitis somehow improves or at least gets better. Because vitamin D has been associated with a lot of immune modulation roles and autoimmune roles, and their role in infective uveitis is one of the questionable thing, and that was the reason that we actually did a subgroup analysis with IGRA status of the patients as well. So yes, this is the area where we need to further explore.
Will you further elaborate IGRA? What is IGRA?
So that is interferon gamma release assay. That is more sensitive and specific test in order to diagnose the ubiquitous uveitis. And in our setting, we have been using these blood tests more frequently to identify patients with TB uveitis. But then again, clinical correlation has been advised in these cases, as that could actually help in getting the perfect diagnosis. Thank you so much.
Did you find any difference between anterior and posterior uveitis vitamin D?
So we didn't separate it. We didn't do did the similar analysis, but yes, this could be one of the things that we could have assessed. So we didn't check if that was more prevalent in anterior uveitis in comparison to the other types of uveitis. But yes, this is one of the things that we could have assessed.
Do you have the data anterior posterior?
Yes, that can be extracted out. Yes, I'll probably look into that. Thank you.
Very good. Now we move to Dr. Adnan Abdul Majid for his talk on role of social media.
Assalamualaikum everyone. Myself Dr. Adnan Abdul Majid. Today I have a very unique topic of role of social media and ophthalmology. So there are no financial disclosures. So these are the outlines of my talk. So first talk about the journey to the digital age, the age from being a human being to the digital being. This is a very historical journey. Humans start learning by writing on the stones, by printing their valuable knowledge, valuable things on the stones that you can see in this picture. But later on in China, when the paper was introduced, so the humans started communicating with themselves with the help of these papers being transported with the help of some animals and pigeons. And later on, as the human started developing, and then it goes on with the, as you can see, in the black slate, writing with the chalk, human keep on learning. Then the era of electricity came, and the human started developing, being very somewhat progressed towards paperless entities, which you can see in this picture. When in the initial stages of the 80s, you can see there's a whole room computer. So basically, the computer seems to be like this. Then it more transformed into a mouse-like pointer and all this computer. Then it progresses further and it converted into a two-plate-shaped laptop. And then now this is the era of a mobile phone. As you can see, all the world is in your palm, and you can do anything you want. So after that, COVID-19 came, and which transformed the world into a digital being. Now everything is starting from the shopping to the online consultation and everything. You name it, and you can have it. Will goes to the digital being. So these are some statistics. According to the Statista, in 2022, there were around about 4 billion people using social media around the globe. Keeping in mind the whole population of the world is around 7 billion, so almost half of the population is using social media, despite of the fact that more than two-thirds of the population of the world is deprived of their basic necessities, but they are using social media. And the estimated that it goes around about 4.4 billion in 2025. The average time individual spend is 61 minutes, which I personally think is a very less amount because I myself spend more than 2 to 3 hours per day spending on social media. So there are popular social media platforms you know more than me, including Facebook, YouTube, Instagram, WhatsApp, LinkedIn, Snapchat, Twitter, and many others. These are some statistics which is showing the most used social media platforms, including the top priority is the Facebook, the second is the YouTube, then goes with the WhatsApp, Instagram, TikTok, and the Facebook Messenger. So what is the use of social media in ophthalmology? Basically, there are many uses of social media and many uses of social media in ophthalmology, but more particularly, for my interest is the teaching and the learning. As you know, people know in every institute, there was in the COVID era, there was an online Zoom learning classes going on, and online WhatsApp group we got, and over there we discussed many things, many diseases, and many from all over the globe. And this is a very good tool to use it to enhance our knowledge and skills. Exam preparation, as the young ophthalmologists who have just undergone the examination, they know that social media is a lifeline, because taking instruction from the seniors, having access to the previous papers, all these are provided easily on the WhatsApp group and Telegram, and books, online books, which cost more than $100, but it can easily be available on any social media free of cost. And career guidance from the senior research survey. You can easily do something. Sorry, you can easily do a research survey on the Google, despite of printing all those research performance, going forward and distributing and then collecting and then analyzing and putting it into the computer and analyzing it. It will cost a lot of time. So there are many things. Communication, intraoperative sharing the operative list, and intra-hospital communications and networking. Networking is important thing. You can network with the international people, your own national people, the legends of ophthalmology. You can take their money and you can take a guidance from them, and there are many things. Another thing includes in practice we can book an appointment from the doctor. There are many apps which are available like oladoc.com, and many others we can easily book an appointment. Patient online consultation like telemedicine has got a much popularity these days, and also the digital marketing for marketing your own practice. So coming to my main theme of the talk is the major YouTube channel which is important for a resident to go through. These are the channels I would like to highlight. The most important, the first YouTube channel of the Pakistan, Dr. Shahid's channel, and it's proud for the Pakistan to have him. And this is the most popular among the residents, and this is very helpful for the residents. The Tim Root and Antia Tolly, he is actually a personal blogger of the ophthalmology. He shares her experiences in ophthalmology residency. And Dr. Glaucoma Flecken, he is actually a comedian as well as ophthalmologist, so you can entertain yourself by reading a lot. One second. So this is academic problem. Dr. Moin channel is most popular. Dr. Hakan channel. This is very academic examination technique, and also the diseases, and also you can discuss it over. You can see it over there. There's also the trend of a specialty-wise YouTube channel. You can see the neuro-ophthalmology channel of Dr. Andrew Aki Ahmed of glaucoma and Richard Allen of the oculoplasty. You can, if you want, you can easily refer these channels for if you want, if you have interest in these specialties. This is a very important picture. In the previous days, this is the picture how the people learn the surgeries. There are many people you can see sitting in the balconies, and the surgeon perform the surgery, and the thousands of people standing above it and seeing what is going on. But this is the era where you learn the surgery. Now you can have something in your palm that is mobile, and you can just log in and you can see any surgery of the surgery you want to see. These are the surgical channel for the cataract surgery, including Aneto Rosatelli, Dr. Deepak Megwal, and Saurabh Patwandar, and Pradeep Mohanta, Uday Devgan. These are the few special channels. So this is my little efforts. Skid Vision Care. I have started my YouTube channel the first year of the residency, And these are the playlists we have gone through. We have covered the multiple aspects of the ophthalmology, including from the career guidance for resident corner and surgery and other videos you can go and access over there. This is the WhatsApp channel, Global Ophthalmologist of Prep Group of Professor Zahid Kamal Saab and many others. These are the Instagram pages which are very popular and helpful. And this is a very special channel on the Instagram, Dr. Haider Ali Chaudhary. He actually make the videos of he's a Retina fellow, and he will make the video of the Retina and then post it. And his video is very much famous and also useful for the learning of ophthalmology and having a very detailed picture of the Retina, photograph, OCT, and you name it, and he can have it. This is the tutorial channel. You can easily see there's a journal of ophthalmology channel. The journal of the ophthalmologist, you can access over there. You can get a guidance from this channel about the journal. And this is the Facebook channel. And these are the useful website, iWiki, iTube, Teamrod. These are the very helpful website, and these websites help me a lot. These are the side effects of using social media: addiction, sleep deprivation, emotional effect, lack of focus and distractions, and dry eyes and headaches. So this is the end of my talk. Thank you.
Thank you, Dr. Adnan, but it was a very, very lengthy presentation, very good presentation, but you must be short and to the point.
Yes.
You presented 4 papers. You have a very good communication skills, all this, but you have to summarize your whole talk within 6 minutes. That is important. Otherwise, you don't have any. We don't have any problems with you, but only the time is the problem. Okay. Any questions regarding his talk or comments? Dr. Tariq, can you?
Definitely, it is the era of technology, and now the modes of communication and learning they have definitely changed from traditional to conventional to digital. Definitely, it is need of the time that we must know the websites and the exact areas or the social media platforms where we can get the relevant information. So it was a good concern, but because of the events. Thank you.
Okay, and now we move on to another speaker, Dr. Usman Mumtaz. Is he here? Dr. Lareb Hassan. No? Okay. Dr. Nabil Akram. Dr. Nabil Akram will be discussing visual outcomes of Harada disease.
Good afternoon, everyone. I am Dr. Nabil Akram, resident of ophthalmology, Lahore General Hospital. Today, my topic of presentation is visual outcomes of Harada disease. First, I would like to give a short description about Harada disease. Harada disease. Harada disease is characterized by severe bilateral granulomatous intraocular inflammation associated with serious retinal detachment, disc edema, and vitiligo. It is an autoimmune inflammatory condition mediated by T cells that targets melanocytes in individuals susceptible to the disease. So the purpose of my studies is to evaluate visual outcomes of patients diagnosed with Harada disease. It is a prospective observational study. So, study was conducted in Department of Ophthalmology, Lahore General Hospital. Total of 12 patients were included in this study, which presented with exudative retinal detachment. And the detailed ocular examination was done, including visual acuity, slit lamp examination, fundus examination. Pre-op and post-op images was also done, and OCT was also done. So, in the examination, they bilaterally anterior segment was normal. On the fundus examination, we seen multiple bilateral, multiple lobulated retinal detachments. Fundus photos and OCT was also done. So in almost all the patients, we gave tablet prednisolone, 1 milligram per kg, and then we called for follow up after 1 week and then after 4 weeks to see the prognosis. So I have for duration of time I have just done 2 to 3 patients. In patient A, 37 years old female presented with us with visual acuity of counting fingers in both eyes. After the treatment, it was 624 in right eye and 618 in left eye. Visual acuity after 2 to 4 weeks treatment was 6:9 partial in both eyes, whereas best corrected was 6/6 in both eyes. So these are the OCT which we done in the patient. You can see the pre-treatment OCT. This was the OCT done 1 week after the treatment, and this was the OCT done after the 4 weeks. So these are the images. You can see multiple lobulated appearances. And this is the post-treatment images. You can see the effect after the treatment, and these are the images after 4 weeks. So there is another patient which was 35 years old female. The visual acuity was counting finger in both eyes, and visual acuity was 612 in both eyes after 1 week and 6/6 after 2 weeks, and best corrected was also 6/6. So this is also an OCT. Uh, this is a pre-treatment, and I have combined the images. You can see the pre-treatment fundus photos, post-treatment after 2 weeks, and post-treatment after 4 weeks. So another patient, 38-year-old female, whose visual acuity was 660 in both eyes, and after 1 week of treatment, it was 6:9 in right eye and 6:36 in left eye. After 2 to 4 weeks of treatment, it was 6:9 in right eye and 6:12 in left eye. These are the OCT of the patient pre-treatment, post-treatment, and these are the images. And another patient, her visual acuity was also counting fingers, and after 2 to 4 weeks, the visual acuity was 6/6. These are the fundus images of pre-treatment and now post-treatment images. So the conclusion is the visual prognosis is good for patients with Harare disease, and the disease may manifest itself with minimum neurological features. So I would like to acknowledge my worthy teachers, Professor Dr. Hussain Ahmed Khan, Assistant Professor Dr. Muhammad Ali Haider, and especially Dr. Hussain Muhammad Baksh. Thank you.
Dr. Nabil, what was the treatment that you adopted for this?
Sir, basically, in all the patients we gave steroids, prednisolone.
Intralesional, what? It's suprachoroidal or what?
So basically, we almost in all the patients we gave oral.
For how long?
Sir, mostly 2 weeks. 2 weeks to 3 weeks. Then we tapered off, and then with the time I also took the fundus images, and the OCT I also did. Mostly, sir, the result was much better after 2 weeks, 2 weeks to 3 weeks. There was one male which took more time. He was 40 years old male. He worked in a factory. So when I took his history, basically his history was he was having so much stress. So I advised him to take a little bit of stress. Then we gave him medicine also, but he recovered. That patient took more time, like 1 month, I remember. But rest of the patients, I have observed that they were much better after 2 weeks, 2 weeks and 3 weeks.
Okay, did you do any investigation before prescribing oral prednisolone?
Sir, I did the routine investigation like CBC, LFTs, RFTs, and if the patient was diabetic, then I did the diabetic profile also. So the RFTs and LFTs we also done in serum electrolytes. So in one patient, I suspected it could be CSCR or Harada disease. So I consulted with my senior, Dr. Sam. So he said that we should do FFA also. So we did FFA also, but it was Harada disease. So then we advised the patient the medicine, oral medicine.
Okay, how will you differentiate from CSR?
Sir, there is an ink blot pattern, and it increases in size in lobules in Harada disease.
Okay, and what precautions will you take while giving oral steroids in a diabetic patient?
Sir, in diabetic patient, the diabetic profile can be deranged while using steroid because we know that it deranges the diabetic profile and it also causes cataracts and it also causes steroid induced glaucoma. So I have to take care of also that. So I would see his diabetic profile. If it is getting deranged, I would like to taper off the medicine.
Okay, did you also think of giving any posterior subtenon Canacort or suprachoroidal?
Sir, in that patient which was getting treatment, in that patient we thought we could give intravitreal, but we didn't give, to be honest. We thought we should give him at least 1 month. Then we will, because his visual acuity was not that much reduced. So we gave him a little time, but he recovered.
Doctor, how long did you follow these patients?
Sir, almost I am images and OCT. I did for almost 1 to 3 months regularly. Then I called them after 6 months. Then I asked them to come 3 months. Then I asked them to come 6 months. Firstly, I asked them to come on weekly basis because, sir, patients are not that much supportive. So they say to us that we cannot come, we are from far away. So the patients were less, I could say, but I asked them to come on weekly basis. Then after, I could say 1 month or 2 months, I asked them to come on 3 months and 6 months.
Was there any case of recurrence or deterioration of real equity after stopping the treatment?
Sir, I haven't seen. I haven't seen a patient, but yes, I have seen a patient which my consultant told me that this cataract has developed after that Harada disease, which he told me that it is a complication of Harada disease. In one patient, there was a cataract. It was an incidental finding by my consultant, which I asked him sir, I am following this patient. Then he said, do you know how this developed? I said, I don't know. Then he told me that this cataract is due to, this is a complication of Harada disease.
It's a complication of radars or complication of the treatment?
So that I can say that I think that this is a complication after the treatment.
So it was unilateral or bilateral?
Sir, it was bilateral.
So most likely.
Yes, sir.
So we must take care
Yes, sir.
of while prescribing
Yes, sir.
steroid management.
Yes, sir.
Look for complications. Thank you.
Thank you so much, sir.
Thank you very much. Now is Muhammad Usman here. Okay, he will give a talk on comparison of treatment outcomes of systemic chemotherapy versus intra-arterial chemotherapy for retinoblastoma.
Good afternoon. My name is Dr. Muhammad Usmanzia, postgraduate resident, Ophthalmology Unit 3, Postgraduate Medical Institute, Amiruddin Medical College, Lahore General Hospital, Lahore. Today, my topic of presentation is comparison of treatment outcomes of systemic chemotherapy and intra-arterial chemotherapy for retinoblastoma. At present, both systemic chemotherapy and intra-arterial chemotherapy are first-line treatments for retinoblastoma in the clinical settings. This study was conducted to compare the clinical use of both therapies and to identify which method is more effective and also to determine if both are necessary for the treatment of retinoblastoma. The objective of my study is to compare the treatment outcomes of systemic chemotherapy versus intra-arterial chemotherapy for retinoblastoma. This was a comparative study. Non-probability conjective sampling technique was used. The study was carried out at ophthalmology department in collaboration with pediatric oncology department and interventional neuroradiology department at Lahore General Hospital, Lahore, from October 2019 to September 2021. Sample size of 46 patients, 23 in each group is taken using 95% confidence level with 80% power of test. The patient included for this study in both set of patients, only systemic chemotherapy or intra-arterial chemotherapy is used as primary treatment method. Eyes were grouped according to international classification of intraocular retinoblastoma system. The patients below 6 years of age from both genders presenting with leukocoria, strabismus or proptosis diagnosed as retinoblastoma were included in the study. Those patients who had previous history of any medical treatment for retinoblastoma or any previous surgery like enucleation for retinoblastoma were excluded from the study. The response evaluation criteria in solid tumor issued by WHO, abbreviated as RECIST criteria, is used to evaluate a patient's response to therapy. It has 4 outcomes: complete remission, partial remission, control, and progression. Patients were divided into 2 groups. The group A systemic chemotherapy was given over 3 days every 3 weeks in 6 cycles. Examination under anesthesia was performed after 3 cycles in each patient. The chemotherapy protocol used consisted of 3 drugs: etoposide 300 mg per meter square body surface area in 4-hour infusion at a rate of 0.4 mg per ml in normal saline, vincristine 1.5 mg per meter square body surface area slowly over 10 minutes in 10 ml normal saline, and carboplatin 600 mg per meter square body surface area in 1 hour infusion at a rate of 0.5 mg per ml in dextrose 5% solution. These are the fundus photographs of some patients, the pre-treatment fundus photograph and the post-treatment. Here you can see type 1 regression after systemic chemotherapy. In this fundus photograph, you can see type 2 regression. Here there is a fundus photograph of type 3 regression, and here you can see the cotton cheese regression. The complications encountered during this procedure included bone marrow suppression, alopecia, ototoxicity, and nephrotoxicity. In group B, intra-arterial chemotherapy was given on an outpatient basis under general anesthesia. The drug melphalan is used in 3, 5, and 7.5 mg of dosage according to body weight of patient. Each patient was given 3 cycles of intra-arterial chemotherapy at 3 weeks interval. Examination under anesthesia was performed before each cycle. The procedure of intra-arterial chemotherapy consisted of groin are prepared and a sheet is placed in femoral artery region. Then under fluoroscopic guidance, a 1.3 mm catheter is guided into the ipsilateral internal carotid artery. Serial angiograms are taken to visualize the ocular and cerebral vasculature. The drug melphalan diluted in 30 ml of saline is delivered using pulsatile non-immediate technique over 30 minutes. These are some of the fundus photographs after successful treatment with intra-arterial chemotherapy. The complications encountered during this procedure included transient ocular side effects like periocular edema, blepharoptosis, transient hyperemia. No event of stroke or other neurologic complications occurred. Bronchospasm is reported in 2 cases and neutropenia in 5 cases. The collected data is analyzed using statistical packages for social science version 29. Comparison of 2 groups is done by applying chi-square test. These are some of the graphical representation of statistical data. The group A included 9 males, 14 females. Group B included 11 males and 12 females. In group A, there were 15 patients of bilateral retinoblastoma and 4 patients in group B belongs to bilateral retinoblastoma. The patients presented with leukoporia, strabismus, and proptosis. In group A, 14 patients had a positive family history, and group B, 8 patients. And stages of disease: 6 eyes in group A belong to stage B, 13 to group C, 15 to group D, and 4 to group E. And in group B, 3 to group B, 9 to stage C, 12 to stage D, and 3 to stage E. The treatment outcome: in group A, 20 eyes showed complete remission, 8 eyes showed partial remission, 4 eyes showed control, and 6 eyes progressed. While in group B, 17 eyes showed complete remission, 4 eyes showed partial remission, 3 eyes showed control, and 3 eyes showed progression. Results: in group A, the stage B showed 100% complete remission, in stage C 76% complete remission and 24% control, stage D 26% complete remission, 53% partial remission, 7% control, and 13% progression. Stage E showed 100% progression. In group stage B and stage C showed 100% complete remission, stage D showed 42% complete remission, 33% partial remission, and 17% control, and 8% progression. Stage E 33% control and 66% progression.
I think you should conclude it.
Yes, just the p-value is 0.03 and the efficacy for group A was 74% and for group B 78%. So on the basis of this data, we conclude that intra-arterial chemotherapy has advantages in eyes with advanced disease. Better globe solvent rate with intra-arterial chemotherapy is possible, and intra-arterial chemotherapy is effective as both primary and secondary treatment option. The overall success rate is higher with intra-arterial chemotherapy than in systemic chemotherapy, and there are less side effects in intra-arterial chemotherapy. Thank you.
Okay, thank you, Dr. Usman. Just want to add that you should be precise and you should conclude within your time limit. That is very important because you have to answer the question from the audience. But now, because of excessive time you have consumed, the question answers won't be asked to you. So that part will be minus from your this judgment. So, Dr. Tariq, would you add something? Okay. We should have next speaker and Atia Nawaz kindly come forward to deliver the talk on diagnostic accuracy of optical coherence tomography to diagnose CME in patients with diabetes, taking fundus fluorescein angiography as gold standard.
Good afternoon, I am Dr. Atia Nawaz, Resident Ophthalmology, IUN3 Lahore General Hospital, Lahore. Today's topic of my presentation is optical coherence tomography to detect cystoid macular edema. What is cystoid macular edema? Cystoid macular edema is defined as retinal thickening of macula secondary to disruption of normal blood-retinal barrier. This disruption causes leakage from the perifoveal retinal capillaries, resulting in accumulation of fluid within the intercellular spaces of retina, involving the inner nuclear and outer plexiform layer. Cystoid macular edema can be diagnosed on optical coherence tomography and fundus fluorescein angiography. Now, what is OCT? OCT is a new technology used for cross-sectional imaging of retina. It is non-invasive, comfortable, and safe. Advantages of OCT appears to optically dissect the retina. Fundus fluorescein angiography is a technique that is used to examine the circulation of retina and choroid by using a fluorescent dye and a specialized camera. The objective of my study is to determine the diagnostic accuracy of optical coherence tomography to detect cystoid macular edema in patients with diabetes mellitus as compared to fundus fluorescein angiography. The study was conducted in Department of Ophthalmology, Lahore General Hospital, Lahore, in duration of 1st July 2021 to 30th June 2022. Study design was comparative study with non-probability purposive sampling. Sample size of 144 patients is estimated at 95% confidence level and taking expected sensitivity of OCT as 96% and specificity as 95% with 7% margin of error. Inclusion criteria includes patients of both genders, aged between 31 to 70 years, patients with clear ocular media and with diabetic macular edema. Exclusion criteria includes patients with nystagmus, claustrophobia, extreme anxiety, pregnant patients, allergic to fluorescein and with impaired renal function or serum creatinine greater than 1.2. As no local data is available to evaluate the diagnostic accuracy and variability is also seen in sensitivity and specificity of previously conducted studies. This research will be beneficial in making the diagnosis with cost-effective and high accuracy. Informed consent was taken. All participants were examined by indirect biomicroscopy and FFA interview was done. And performer was designed to evaluate and enter the name, gender, registration number, and address, visual acuity, and FFA and OCT. Data analysis plan was included. Data was entered and analyzed by SPSS version 36. Numeric data like age and duration of diabetes mellitus was presented as mean plus minus standard deviation. And the qualitative data like gender, hypertension, and smoking was presented in frequency and percentage. For comparison of quantitative variables like age, independent sample t-test for two groups was applied. For qualitative variables like gender and symptoms, Pearson chi-square test was applied, and p-value less than 0.05 was taken as statistically significant. This is the limitation of study, single center, and limited sample size. This is the optical coherence tomography showing all the layers on the right side, all the layers from the ILM to the RPE with quantitative measurements of the cystoid macular edema is shown. This is the FFA image showing the petaloid pattern in the center of cystoid macular edema. So result shows out of 144 patients, we do the 72 patients under an OCT and 72 under an FFA. They were selected by random sampling. Group A, age shows 42.67 plus minus 6.81 standard deviation in group 1 and group 2 44 plus 0.15 plus minus 7.23 and gender 40 patients in group 1 males and 32 females and laterality 20 unilateral 52 bilateral and eye age right eye left eye 12 and bilateral 52. This shows the p-values and statistically significant or non-significant. This is the graphical representation of the variables, and this is the symptoms showing visual syncope. A visual syncope in FFA 10 patients underwent visual syncope, and 8 patients had vomiting, and 20 patients had experienced urine discoloration, and 12 patients experienced neck stiffness, and 10 patients experienced neck stiffness in the OCT, while none of the symptoms experienced by the OCT patients. So results conclude that with OCT we were able to diagnose and quantify cystoid macular edema without any complications as compared to fundus fluorescein angiography. We were able to monitor the disease progression and treatment results with OCT. Hence conclude that diagnostic accuracy of OCT is better than FFA. Thank you so much. House is open for any questions.
Thank you, Dr. Atia. Any questions?
Yes.
ये जो FFA पे हम कैसे वो देखेंगे भी आप कुछ बता रहे थे
We can see the petaloid pattern of cystoid macular edema on fundus fluorescein angiography.
पेटलोइड पैटर्न कौन सा
Petal-like, the leaf petals होते हैं ना, उस तरह की petals are due to dye accumulation in the outer plexiform and inner nuclear layer.
Madam, could you please explain the FFA findings? OCT findings.
OCT different layers?
Yes.
Yes, we can see the different layers due to reflectivity patterns. Like RFL or RP layers reflect high reflectivity, and inner nuclear and outer plexiform shows medium reflectivity,
and the photoreceptor layer shows the lowest reflectivity. So we can differentiate from the reflectivity patterns on the OCT.
Doctor, what is the other advantages of OCT over FFA?
Other advantage is it is non-invasive, it is comfortable and safe, and we can repeat it after treatment. We can see the monitoring of the patients after giving any treatment of the cystoid macular edema. While we cannot repeat like after 1 month or after 2 months, if the patient experience any symptoms in FFA, then we cannot repeat it after any treatment.
Okay, in vascular lesions, identifying vascular lesions, OCT and FFA, if you compare, definitely if you say that OCT is better, how can you improve your suggestion?
OCT is better in some diseases, but FFA for the disease like CSCR it is better. Yes, for the disease like CSCR or vascular disease, but
Can
we can
we
repeat.
can we detect vascular pathologies from by OCT also?
Yes, we can detect if there is any CNV. We can see. We can detect in OCT.
Thank you.
Okay, thank you, Dr. Athiya. Very nice presentation. And you were able to finish on time as well, and you explained it properly and also give question answers. And I asked Ahmed for treatment outcomes of Group D and Group B retinoblastoma.
Good evening, ladies and gentlemen. My name is Dr. Ahmed Fawzan. I am a resident ophthalmologist at Lahore General Hospital, I Unit 3. Today, the topic of my presentation is treatment outcomes of Group D and Group E retinoblastoma. So, as we all know that retinoblastoma is the leading cause of blindness and it leads to enucleation. So, international classification of retinoblastoma has classified it into groups A to E. Normally, in groups A to C, we have a better chance of globe salvage, but in group D and E, the chances of globe salvage is approximately less. So, with the introduction of intravitreal chemotherapy, the previous techniques of external beam radiotherapy which have been now abandoned, and so globe salvage is very challenging while we are dealing with patients in group D and group E diseases, while we rely solely on the intravitreal chemotherapy. Recently, intra-arterial chemotherapy has been popularized as a primary mode of treatment for Group D patients, and it has reported a high success rate. What is the importance of globe salvage? Globe salvage marks the treatment success in retinoblastoma. So the purpose of our study was to report management course and in Group D and E retinoblastoma patients that were treated in our centers with intravitreal chemotherapy and adjuvant therapies. Material and methods of our study included a study which was retrospective, observational, and longitudinal. The duration of study was approximately 5 years, and it was conducted in Lahore General Hospital. So these are the inclusion criteria, which included eyes with Group D and Group E retinoblastoma. The classification was made on ICRB classification. Our study included 81 eyes which were classified as Group D and Group E diseases. SPSS version 36 was used. Chi-square function was used to compare the treatment outcomes in different strategies, and Kaplan-Meier analysis showed globe salvage expectancy. So we divided our patients into 4 sets. The first set received a primary intravenous chemotherapy. The second set received primary and second line IVC. Third received a combination of primary IVC and intra-arterial chemotherapy, and the group 4 received IAC alone. So these are the images that show different treatment modalities that we use: laser therapy, cryotherapy. This is intra-arterial chemotherapy, and this is a video that I kindly pause forward it. Okay. So we are injecting melphalan here, intravitreal chemotherapy. Okay. So the treatment response was assessed in terms of tumor size, its color, vascularization, calcification degree, and tumor focality and density. Our treatment failure was defined as an inadequate response to main tumor or its seedings. This is an outcome of treatment failure, that is enucleation. So this is the data showing in our set 1, we had group D patients and group E patients. So a total of 8 eyes were salvaged and 3 eyes were enucleated in our set 1. In set 2, we succeed in salvaging 15 eyes and 7 eyes were subjected to enucleation. In set 3, 8 eyes were salvaged and 3 were enucleated. In set 4, a total of 14 eyes were salvaged and 4 were enucleated. So totally, we succeeded in achieving 45 eyes salvaged and 19 eyes were enucleated. So, results in Group D, 39 eyes out of 52, which were included in Group D, were salvaged, and in Group E, 6 out of 29 eyes were salvaged. So, overall salvage rate was 75% in Group D and 20.68% in Group E patients. The treatment failure, that is enucleation, it happened in 13 patients of Group D and 6 patients in Group E. Only 2 patients had an anaphylactic reaction to drug carboplatin. No metastasis or deaths were reported, and the p-value for our study was 0.01, which shows a very good significance. So, in conclusion, we can say that globe salvage for group D is higher than in group E. Intravitreal chemotherapy with the use of adjuvants showed a globe salvage rate of 60% in group D disease than in group E. But intraarterial chemotherapy cannot be used as a first line because of its potential risks of being systemic spread, and it requires advanced expertise and infrastructure as well. So that's how I will conclude. The house is now open for any questions, please.
Sir, what is the dose of melphalan?
So we inject melphalan at a dose of 3.5 to 7.5 milligram, which is diluted in 30 ml of normal saline and is given over a period of 30 minutes via femoral artery. So we keep on following up these patients every 2 to 3 weeks, and we take their fundus photographs to monitor the treatment outcomes until they are at the age of 6 years. Yes.
Okay. How frequent do you see retinoblastoma in your setting?
So quite frequently we see retinoblastoma in our settings because our Professor Khan shows special interest in these cases. So we are seeing retinoblastoma quite frequently in our setup.
So intra-arterial treatment is better as compared to the systemic.
So it has shown good results when especially used with adjuvant therapies. Intra-arterial chemotherapy has shown good results as compared to intra-arterial chemotherapy alone.
How many cases were bilateral?
Sorry, sir.
They were unilateral cases or?
Sir, mostly they were unilateral cases. Mostly.
You can over check your slide. There is the written that how many were bilateral. You just scroll back.
Okay, thank you, Dr. Ahmed,
Thank you.
for your presentation. A very good one. Is Dr. Hafiz Mubashir Farooqi here? Okay, he will give a talk on comparison of the efficacy between an intravitreal and suprachoroidal injection of triamcinolone for the treatment of refractory macular edema.
Assalamualaikum. My name is Dr. Hafiz Mubashir Farooqi. I am resident in I-Unit 2, Lahore General Hospital. The topic I am going to present today is the comparison of the efficacy between an intravitreal and suprachoroidal injection of triamcinolone acetonide for the treatment of refractory diabetic macular edema. As we all know that diabetic macular edema is one of the most leading cause for the loss of central vision in diabetes with diabetic retinopathy. Although there are multiple ways of treating diabetic macular edema, like we can use anti-VEGF or lasers or steroids, but the use of locally applied steroid has proven their efficacy in certain clinical situations as first-line treatment. So today we are going to discuss about the triamcinolone acetonide as the first-line treatment objective. The objective of my study is to compare the efficacy between an intravitreal and suprachoroidal injection of triamcinolone acetonide for the treatment of refractory diabetic macular edema. The type of my study is quasi-experimental study in which non-probability consecutive sampling technique is used. Subject selection is according to the inclusion criteria. In the next slide, I am going to explain the inclusion and exclusion criteria. According to inclusion criteria, both gender, male and female, age range from 40 and above are included. Central retinal thickness more than 300 micrometer are included, and the best corrected visual acuity should be poor or equal to 0.8 log MAR units. Duration up to 1 month of onset of symptoms. Exclusion criteria include those people who have posterior uveitis using anti-glaucoma or have new vessels on their body. So total 46 patients are included in this study. They were divided into two groups. One group include those who were given suprachoroidal triamcinolone acetonide, and the other group include those people who received intravitreal triamcinolone acetonide. So in the injection triamcinolone acetonide 4 mg per 0.02 ml was applied under aseptic condition in intravitreal space with 27 gauge needle. And for suprachoroidal space, we use an improvised technique. Patients were examined at 1 week, 1 month, 2 months, and 3 months interval. At each follow-up, best corrected visual acuity and OCT are done to see the improvement. At the first week, follow-up was done actually to see any immediate complication or anything. At the first week, out of 46 patients, 8 patients had subconjunctival hemorrhage, 4 patients had raised intraocular pressure, and 3 patients developed cataract due to lens touch. Okay, now we talk about the results. I use the SPSS software for data analysis in which pair t-test and Wilson sign rank test used for significance, chi-square test for the comparison of outcome variables. A p-value of less than 0.05 is considered as significant. In the group A, as you all know, who get the suprachoroidal injection. Pre-injection central retinal thickness was 436 plus minus 50 micrometer. At 1 month, it improved up to 311. At 2 months, it improved up to 300, and at 3 months, it improved up to 280. And if you see the best corrected, it was 0.9 log MAR, then it improved to 0.6, then improved to 0.3 at 3 months. Okay, in the group B, pre-injection was 412 central macular thickness, which improved up to 380, then 352, and in the third one it improved up to 312, and the best corrected visual acuity improved up to 0.6. But in group A, as we all know that, it's improved up to 0.3. That's the important thing. Okay, that's the graphical representation of my results. As we all can see, blue represents the suprachoroidal group and red represents the intravitreal group. In the intravitreal group, we see that there is less improvement as compared to suprachoroidal. This is the comparison for best corrected vision. And these are a few photos pre and post treatment which show significant improvement. Okay, now the conclusion. According to the data of 46 patients, it is concluded that suprachoroidal triamcinolone acetonide has better efficacy and outcome as compared to intravitreal route. Intravitreal route has more chances to develop cataract, increased IOP, vitreous hemorrhage, and retinal tears. Okay, the limitations of my study obviously is a short sample size and it's a single center study. Thank you so much.
Okay.
House is open for the questions.
Okay. How do you inject intravitreal triamcinolone?
Sir, we measure the position from the limbus for the according to the phakic status of the eye. If it is a phakic eye, we apply at 3.5 mm, and for the phakic eye, we can give up to the 4 mm.
Okay. Do you inject triamcinolone like that only, or do you first titrate it and then inject it?
Sorry, sir, I didn't get your question.
Do you inject triamcinolone, prepared one, shake it and give it, or do you lift the needle and only inject the sedum part of that, like clear part of that?
No, sir. In our setup, before the procedure, our staff prepared it in an antiseptic situation and provided as it is.
What I want to ask is that
Was
the
it
precipitate.
filter or precipitate?
Yeah, the
There is
precipitate.
one video where he took that
Yeah,
particle
yeah,
away and only see.
yeah.
So you're asking about the filtered solution and
Yeah.
precipitate, yes.
Yeah,
At times, yes, sir, we, through filtration we applied, otherwise we directly do.
directly. And if you apply directly, sometimes what happens is that the precipitate will collect on the macular or fovea area. That may become troublesome.
Yes, a filtered procedure is the better one.
And Dr. Pagan is an expert in it and hopefully.
I just can't hear from yesterday's man. मुझे बता क्या पूछ रहे हैं सर?
Okay, this filtered apply करके के directly.
फिल्टर लगाने की कोई ऐसी जरूरत नहीं है। फिल्टर लगा के हमने व्हीकल को ही रोकना होता है। तो व्हीकल चला भी जाए तो उसमें कुछ नहीं होता, क्योंकि अभी तक सुप्राक्रोइडल का जो इन्वेंटर है ना वो मीन है जो इधर आया हुआ है। ही इज द इन्वेंटर ऑफ सुप्राक्रोइडल कैनाकॉर्ड। तो जो उसके बकोल है इसको व्हीकल के बगैर नहीं लगाने का, जितनी डोज व्हीकल के साथ ही होती है वही ठीक है।
नहीं सर, सुप्राक्रोइडल तो वेहिकल के साथ ही है,
इंट्राविट्रियल पाकिस्तान में बगैर व्हीकल के नहीं है। इट इज विद उसका तरीका ये होता है कि आपने लेना है उसको पहले खड़ा कर देते हैं थोड़ी देर, फिर लगाने से पहले पूरा शेक करते हैं और एज यू आर रेडी जस्ट इंजेक्ट इट इन अ मोमेंट।
Yes, this I wanted to ask you from previous slide. Any questions for Dr.
जो ट्राइमसिनल नोन है उसके अलावा हम कोई इंजेक्शन स्टीरॉइड क्यों नहीं लगाते?
अच्छा, how do you inject the suprachoroidal prepared needle जो आपको जो available है मार्केट में, या खुद बनाते हैं आप?
नहीं सर, हम वहाँ खुद बनाते हैं। 24 गेज कैनुला लेते हैं, उसका जो 27 गेज नीडल है उसमें इंसर्ट करते हैं और 1 mm की टिप छोड़ते हैं, उससे लगाते हैं।
But sir, since the advent of the prepared needles,
Yes.
we have shifted ourselves to the prepared needles.
Yes, because sometimes when you prepare it yourself, there is a problem that it may get intravitreal or and do you feel that the patients after suprachoroidal complain of more pain as compared to intravitreal Avastins or Ducentis or whatever you give? Is it? So what do you do at that time?
So immediately we take the Equistep.
Yes, you don't wait.
Yeah.
Okay.
Sir, we have included it as a part of
Part
procedure.
of it.
Whenever we apply suprachoroidal, we always take
Always.
in a proper sterile environment. We apply the offside. We have the 15-degree with us, and immediately take the Equistep.
Because otherwise the pressure will be high and that will cause more problems.
How much
So it is tracked.
Sir, the same as that of starting from the dose of the anti-VEGF from 0.05 to 0.1 you can get.
Okay. Next, okay, thank you very much. Do we have Taimur Ashraf Khan? Okay, there is one presenter, Lareb Hassan. Is he here?
Yes, he is.
She's already
And he will present a talk on outcome of 23 versus 25G microincision vitrectomy for diabetic retinal retinal detachment.
Good morning, I am Dr. Lareb Hassan, postgraduate resident, Lahore General Hospital, Lahore. Today, topic of our presentation is outcome of 23 gauge versus 25 gauge microincision vitrectomy in diabetic traction retinal detachment. Diabetes is an epidemic disease with prevalence ranging from 10.9% to 37.5%. In international studies, while in Pakistan, the prevalence of diabetes has been reported to 10.6% to 19.0%. Diabetic retinopathy is one of the most common complications of diabetes and is one of the leading cause of blindness in the middle-aged population. It has been divided into two groups, proliferative and non-proliferative. Diabetic retinopathy with macular traction is a serious condition, and vitrectomy surgery has been used to deal with this condition. However, with the advancement of the technology, more refined instruments and techniques emerged which led to microincision vitrectomy system. There is no local published data present on the topic, and almost all previous studies which were done only include 23 gauge and 20 gauge, but this study showed that the intraoperative and the post-operative outcomes of 25 gauge were significantly better than 23 gauge. The objective of my study is to compare the intraoperative and the postoperative outcomes of the patients with diabetic macular traction with retinal detachment treated with 23 versus 25 gauge microincision vitrectomy system. The study was conducted as Department of Ophthalmology, General Hospital, Lahore from 1st July 2021 to 30th June 2022, and the study design was comparative study. A sample of total 38 cases, which was increased to 60 due to small sample size, 30 in each group, is calculated by the following formula, keeping confidence interval of 95% and 80% power of test while taking mean post-operative pain score was 4.28 plus minus 1.24 in 23 gauge group versus 3.2 plus minus 1.08 in 25 gauge group. This is the sample size formula, and a convenient sampling was done. Patient of both gender with ages in the range of 30 to 70 years having diabetic retinopathy as per operational definition. Patients who have endodampened by the air and the fluid during surgery were included in this study. Sulfur hexafluoride was used as endodampener where it is needed. Patients on antiplatelets and anticoagulation therapy or having uncontrolled blood pressure or diabetes as per investigations and clinical record were excluded. Patients who had already had a procedure for diabetic retinopathy as per history and clinical record were also excluded. Patients having vitreous hemorrhage on clinical presentation were excluded too. Data was collected and analyzed by SPSS version 36. Numerical variables like age, HbA1c levels, operative time, post-operative pain score, and astigmatism will be presented by mean standard deviation and range. Independent t-test will be applied for the comparison of mean operative time, post-operative pain score, and astigmatism between the two groups. Categorical variable like gender and need to suture the port will be presented as frequency and percentage. A chi-square test was applied for comparison of frequency to need the suture the port between the two groups. Data will be stratified for age, gender, HbA1c level, post-stratification. Independent t-test were applied taking p-value of less than 0.05 as statistically significant. The study helped to determine the outcome of two different gauges and to determine which is more beneficial for the local population. Limitation of the study was it was conducted on limited number of patients and only show results of the one center. It will not include result of other gauges and other modalities available for the treatment of. In this study, 63 eyes from 60 patients who had vitrectomies were included. 22 individuals had one eye treated with devices that were 23 gauge and 23 with 25 gauges. 3 of 6 patients who had treatment for both eyes and 23 gauge needles, and 3 used a 25 gauge needle. The 2 study eyes recovery time between operation ranged from 38 to 11 days. The mean age in the 23 gauge group was 67.66 plus minus 8.41 years, while the mean age in the 25 gauge group was 68.84 plus minus 8.45 years. Independent t-test was applied, t calculated 2.108 and p-value was 0.039, which is considered to be statistically significant. These are the graphical representation, and this is the table of the post-op complication in which retinal tear, retinal detachment, vitreous bleeding, ocular hypertension, hypotony, or subconjunctival bleeding and endophthalmitis were seen in both groups. This is all the graphical presentation. Patient with common vitreoretinal disease such as macular, epiretinal membrane, macular hole, laminal macular hole, vitreous hemorrhage, vitreous opacities, vitreomacular traction syndrome, or macular edema were enrolled in this study to compare the safety and efficacy of both measures. Finding of vitreoretinal surgery indicated difference between the 23 and 25 gauge vitrectomy system with regard to intraoperative and the postoperative safety, surgical duration, and long-term visual acuity result. The finding implied that the 25 gauge vitrectomy is better than the 23 gauge in ordinary clinical practice for more situations requiring vitreoretinal surgery. This is the short video. Can you say it?
I don't think we have time.
Okay.
We don't have.
Okay.
so showing that there will be done, but that we have already done the study.
Yes,
But
sir.
still your slides were showing that it will be like this, it will be.
You should have corrected it properly. Okay, and your data, the thing is that what the results are important for the audience. That needed to be more present at the time, not the initial part of that. So the results, we are more interested in the results. So in nutshell, what do you include in it, and what were your results in it?
25 years
25, yeah,
is better.
is better.
Yes, sir.
So in what sense it is better?
So it is better like we don't have to need to switch the port
Okay.
and best visual acuity is better in 25 years.
Okay, thank you very much. Any questions for Dr. Lade? Okay, now we move on to, is any other speaker here? No, okay. Maybe he's not here. Dr. Taimur Ashraf is not here. So with this, we come to the end of free paper session, paper 5, and I want to congratulate all the residents who have very nicely presented all the presentations, and special credit goes to your mentor and your supervisor who have guided you to actually deliver this talk. And you are our next generation of ophthalmologists, and we have great hope with you. And best of luck for your future. And your result will be displayed shortly. And Dr. Tariq will be.
The results will be announced during your closing ceremony. We appreciate your efforts, what you have done. It is basically an opportunity to prepare yourself for your future presentations at international level. So what is the requirement and what is. So basically we judged you on time, the originality of the idea, the expression, how do you express the structure of presentation which contains the maximum marks 50, and then what statistics you provided, and finally the question. So there were the various items which were on which you was